we have everyone take their seats so the panelists come up and get started. Again, for those interested in sitting in on the planning your first worksite center, it is just next door, and that will be starting as well. So many of our worksite centers began as occupational health centers. First aid stations, company nurse, company doctor. And what firms were finding is that someone came in, they'd say, "Doc, you know, I hurt my hand. By the way, could you check my diabetes medication or check in my ear?" And it became more and more of an interest in offering broader services at these centers. And so now we're at the point where there's a real interest in merging health services as well as primary care and chronic disease management services. But there are a number of challenges, and we're going to use this panel to talk about that. So with that, I'm going to ask our panelists to introduce themselves. So Darcy, would you start, please?
Hi, I'm Darcy Glasses. I'm the Senior Director of Clinical Operations for On-Site Care. We have been, or in the primary care workspace clinic operations, but over the years have kind of morphed into providing occupational health for our clients as they come to us with their challenges and wanting to integrate occupational health into their primary care clinic. I've been in the occupational health and the clinical side of the workplace clinic for about 11 years.
Thank you. Kay?
Thank you. Kay Yoder. I am in charge of environmental health and safety and business continuity for Southern Glazers Wine and Spirits. They're the largest beverage alcohol distributor in the nation. I apologize, I didn't bring samples. We were interested in originally setting up some on-site clinics for occupational health reasons. We have a lot of fleet drivers. We need, DOT drug screens, pre-employment screening, things like that. But over our years, we have found that so many of our employees don't have the primary care physician, and with the convenience of the on-site, we're now doing a lot more primary care.
Great. Thank you. And Mike?
Hello. Mike Ryan. I'm the EVP and COO of Concentra's on-site health division. Not all of Concentra. There's 3 COOs at Concentra. For those of you that aren't familiar with us, we are the largest provider of occupational medicine in the country. About 540 public-facing locations, and we have about 160 on-site health locations as well, which is the part of the business I get to oversee. And they vary in scope and service from single providers all the way to full-blown 24/7 operations, diagnostics, as well as both OCHEL and primary care.
Great. Thank you very much. So let's just get a flavor from the audience. How many have a separate OCHEL only operation and not primary care? There's a few. How many have an OCHEL and a primary care, but they're separate providers?
Separate providers or separate locations?
Well, different providers. Okay. And how many have an integrated OCHEL and primary care in one location? Okay. All right, so that's the scenario that we're finding our membership in and others employers, and so let's get into that. So Darcy, let me ask you to start out. What's the difference between an occupational health center and a primary care center?
Well, the biggest difference is occupational health. There's different guidelines we have, and primary care is obviously primary care. With occupational health, the fact that what we have to do in the clinic is somewhat reported back to the employer can be a big challenge. And with primary care, knowing that the patient is coming in for their overall primary health, you're looking at the whole body instead of just focusing on maybe a specific injury or a specific test that needs to be done to be able to perform their job.
And for you, Kay, how do you define the differences between them?
I don't know that I can elaborate better on what Darcy said. I don't. For us, we're not. It's hard to keep the privacy separate, and so I think that the way she explained it was probably perfect.
Great, right?
Yeah. So I think biggest concern is privacy. And then there's varying degrees of outcomes, right? Like what you're looking for when you're an employee being treated for a work-related injury versus a primary care injury or diagnosis is sometimes different. It's perceived as different. There's a different stigma in the work comp world. I've lived it for 21 years. I can tell you 98% of people that get hurt at work want to get better and go back to work. So, but privacy is big, so having the systems and the reporting systems set up to handle that is key. In the work comp world, you don't just have the employee, maybe a dependent, or and the payer. You have the employee, the dependent, the employer, sometimes a TPA, sometimes a nurse case manager that works for the TPA, sometimes another nurse case manager that works for the insurer, and then you have OSHA and other governing bodies that sometimes you have to report to, in addition to the Federal Carrier Association. So it gets a little complicated, but I think it goes back to Jeff from Marathon said it earlier in the technology talk. This goes back to process, and we can use technology to leverage that process and make it easier to eliminate human error.
Thank you. So Kay, let me ask you, how do you address the trust of confidentiality? How did you do that in your population? And do you use the same providers for both, or do you separate?
We use the same providers for both, and I think it's about the culture and the fit for that market that it's in. It's completely different to build the trust factor at an on-site clinic, you know, which takes a lot of communication and informing, to the employees about what their options are to them. But the trust that we use the same provider, and because of the fit, it has been very successful in our markets.
Mike, how do you recommend that employers deal with trust and confidentiality? And do you recommend using the same provider, or how does that work?
Yeah, so depending on the size of the on-site, in most on-sites we use the same providers. In fact, I don't think we have, out of our 160 or so, we have 0 separate providers. I work with sites that have a separate primary care site managed by another vendor. So it goes a lot to what you'll talk about in launching on-site. So it's communication, open, upfront communication, again, meetings with key decision makers. So unions are a big one. They're worried about their employees' rights, usually a little bit more on the workers' comp. When it comes to primary care, it's about access and getting benefits and what are the benefits for the employee. And then it's also corporate leadership. So, risk, safety, a lot of times doesn't have much visibility to the primary care side of the house. Some regulators, that just happens to not be the case. They're a very open, unsiloed company. And a lot of companies, we know everybody on the workers' comp side of the house and do, in our centers, tens of millions of dollars of business with the company. The benefits and HR side, they're sent up to primary care. They don't even know who Concentra is. So it's really having that open communication across the organization as well as with the employees that are going to be accessing it. That helps a lot with the barriers.
Great. Darcy, how do you handle the integration, or how do you deal with the trust and confidentiality issues?
I don't know that there's really a secret sauce. Nobody figures out one, There's always a huge trust issue, as you know, between employees entrusting the provider or the health specialist not sharing information back with the employer that they don't want to share. I agree that the biggest thing is education, educating different parts of the company, the safety, the risk, if there's the leadership, but also educating the individual patient when they come into the clinic. So it's a great opportunity when they come in, if they're coming in for an annual surveillance exam, or they're coming in for their random drug testing, to educate them at that time about the options with the primary care side and the difference between primary care and the occupational, and what is being shared back with the employer. They realize that when they come in for anything that is work-related, their company is going to get some information back. They understand that. and being able to differentiate between the primary care and the occupational and helping to educate them on an individual level. We've had providers where we actually just sit down with the patient and show them the documents that we have to submit back to the employer so that they see exactly what we're doing. And it helps them to understand that the patient just sat here and talked to me about their work injury, but during that discussion, there was a diabetes issue that came up. They see that we're filling out this form and we're sending this information back, but the diabetes information is not on there, and it helps to develop that trust.
Thank you. Mike, tell us, what are the challenges in either using the same providers or in trying to integrate them? Can any doctor, any nurse do both? Are they comfortable in dealing with these two kind of medical practices and legal issues? And if you need to integrate them, what needs to be done?
Yeah, so our providers do both. I think the biggest thing is in our world of occupational medicine, very few physicians come out of school with board-certified OCHEalth or wanting to practice in occupational medicine. So we have a very robust platform to train physicians to practice in occupational medicine. We get a lot of primary care doctors who come work for us to become occupational medicine physicians. And really, we practice primary care in the occupational medicine world. So there are similarities. You can handle a lot of the reporting and the do's and don'ts in your systems, but there is the training aspect, right? So when you see somebody for a work-related injury in a normal primary care site, they're off for 3 to 4 days. So they follow up next, or go get an x-ray and come back. In the health world, there's transitional duty. What is the light duty program? And so making sure your clinicians are aware of all of that and educated. It's easier at an on-site to do that because there's an onboarding process, there's an implementation process, and I think you go through those key deliverables and what both sides are looking for in the implementation and the training, and that really helps. If you have to add it on later, it's the same thing, you just sort of walk into it a little bit later and then what are our pain points, what are we solving for, and where are the key differences in how you're treating the patient. But overall, if the patient's having a good experience, they're going to get better, and it helps build the trust that Darcy was just talking about, and the employer is generally happy when the patients are happy, and you can fix most of the little bumps that happen.
Just as an aside, if you have any questions, text them to me at 847-606-5527. Darcy, how do you integrate? You start out with primary care as well. How do you integrate these? Are there challenges? Can you use the same providers? And how do you approach that?
So we do use the same providers. We do, again, when we have a primary care provider that we usually will start with the primary care provider because when you're doing primary care, they need to have that knowledge. And then we will do the same thing, train them on occupational health and the differences and helping them to understand, the biggest hurdle is the difference between primary care and occupational medicine and helping the provider to understand, providers just want to take care of their patients and again, you go to a primary care with a workplace injury and you're going to get a prescription for ibuprofen and you're going to take 3 days off and now the employer has a reportable incident. If we can do that in the clinic with the provider that they see for their primary care already and the provider understands, okay, I'm going to give them some over-the-counter ibuprofen and have them rest for a little bit, get them back on the line as fast as I can, as long as it is safe for that patient. The employer is not going to have that reportable incident. So helping them to understand that we don't always jump to what you normally would jump to in a primary care setting when it's an occupational injury.
Thank you. Kate, could you comment on that as well?
So that piece that Darcy was just talking about is so key for those of us who are trying to minimize our OSHA reporting and reportability, because that's really where we're measured in a lot of the lagging metrics that are out there, right? Every company has to report. And so having that understanding is extremely beneficial to the organization. I'd say the second thing is that when you have the primary care on site that's also doing occupational health, they know your business. So for us, it's at our site. They can walk out in our warehouse or watch a driver and help us with what the return to work program is and what the transitional duties are that the person could do on our site to get them back to work sooner. And so it is really beneficial. In our case, we also have some athletic trainers that help with stretching and musculoskeletal injuries. And so we have had where they're the primary care, where somebody had, for instance, a non-work related injury, but they're coming to the clinic saying, hey, can you help me with this? Because I really don't want to miss a day of work and I hurt myself at the gym, right? And so it just gives us a benefit on both sides, and they have it.
There was recently been stories about one particularly large firm that supposedly was putting pressure on their clinic staff not to report injuries, just to treat them. How does the clinic staff address that, or how should employers address that? Because you say we're trying to avoid reportable conditions, and yet we want to provide the care to employees. How do you respond to stories like that? Is that just unique to that culture, to that employer, or do you see that in the industry? How are providers dealing with that? Darcy?
I think that's a unique story. For us, all of our clients that we work with completely support our philosophy, and we've got to do the right thing every time. It's important that patient is taken care of appropriately. Yes, we want to prevent reportable incidents, but that patient is what is important, and making sure that patient is taken care of appropriately. If a client were to ask us to do something, I think we'd have a problem.
Yeah. Does the C-suite get involved, okay, with you and making these kind of directions?
We are like in my business, we're a family company, and we treat everyone as if they're family, and the patient care is the #1 priority for our clinic. So there's no trying to push reporting underground. We're gonna do what we can to prevent it, and when it happens, and it does happen, then we're gonna treat them, but hopefully get them back to work as soon as possible.
Right. Michael, you experienced that at all?
So I may see a little more of this. Not as much in our on-site world, because again, it's an established partnership, and there's lots of stuff you can do to prevent injuries, early symptom evaluations, using athletic trainers, physical therapists, to help before an injury even really needs clinical care and becomes reportable. The clinicians are not reporting, typically, unless you have an RN on site, and the company's usually going to enter their data sometimes, but it's the company's responsibility the employer's responsibility to report. There are discussions, and I think the typical way we try and handle it is, case reviews and escalated case reviews, because mistakes are made. Sometimes a prescription is given when it really wasn't necessary, or somebody was put off of work when they weren't necessary, but that's like your typical case management care chart reviews that we do on a regular basis, and should be picking that up. But there are employers that incentivize their folks on reportability, and that's when it gets tough for both the employer and the clinicians, because they will call and ask and question. And then there's certain employers that rely on low rates in the construction field and stuff of that nature to really get bids, because if their reportability goes too high, then they lose out on government bids and stuff of that nature. So it is a problem to navigate, but it really depends on your industry and the relationship. And again, it goes back to what Darcy and Kay said. If you treat the patient right, it's usually not an issue. And if you sit down, and 99% of the times if you sit down, especially at an on-site and do a case review, everybody understands why it ended up meeting reportability status or not.
Kay, how do you measure the success of your center, of the Occ Health and the primary care? What metrics do you use, and what do you put in performance guarantees?
It's difficult to measure outside of the standard ROI. So when we work with Concentra, We put a projected, budget out there. We said, okay, this is how many new employees we have, how many DOT physicals, all of your typical things that we also look at not having time away from work to go to a doctor's appointment. So a lot of the soft things that make up where the savings are, but we're really seeing the savings. We do a patient satisfaction survey after every clinic visit, which have been remarkable, but I would say the biggest measurement is word of mouth, because what we were hearing when we opened up clinics last year around this time of year, that people hesitate bringing their kids for their sports physicals, right? Because they couldn't get anywhere else, and we see dependents at our locations. There's no copay. So once you go to visit the site and you don't have to pay anything, all of a sudden it becomes more attractive for a family of 5 to go there to get their sports physicals, right? Because each one of those is a copay. And then when things happen, when an employee, we've had a couple testimonials from employees. So we as the employer cannot share specific medical information, but if the employee was treated in a way that they want to share with everyone else, which is what happens, then that's the best measurement for us, where the person got such an amazing turnaround, a diagnosis that saved their lives, waited in an emergency room for 4 hours and then decided to go to the clinic and got seen right away. I'm diagnosed with scoliosis at the age of 18. I'm at a pre-employment physical and it wasn't been diagnosed before. Like things, real life stories that then are employees talking about the clinic to other employees. That's the best measurement.
Well, Darcy, what performance guarantees are you asked to do, or what do you offer? And what metrics do you and the employers use for success?
Performance guarantees are dependent on our client. There's a lot of different performance guarantees. We worked specifically with each individual client to come up with the performance guarantees. So that one's a little bit harder to identify because we have so many different ones. Measurements for success, as you mentioned, are hard to prove. It's a lot of the patient coming back and having a good experience and successful experience. Some of the things we have tried to do to show the success of the programs is a simplified ROI by showing, okay, if you have this employee that would have gone out to a third-party vendor to have their new hire physical drug test or their injury taken care of, this is what you would have paid. But because you have a clinic and it's all integrated into the clinic, you've saved all of that. And kind of trying to show that way, kind of the value of having that health inside the primary care clinic. Patient satisfaction is another great way to show some success when you've got patients that have had a great experience. And they're also the great ones to spread the word on confidentiality. And I went to the clinic and I talked about specific conditions that didn't get shared. And I know that I can trust them. So having those good experiences with the patients is a great way to show the success of the clinic.
Thank you. Mike, what kind of performance guarantees and metrics you use?
Yeah, so just a couple. Obviously, the direct ROI is important. So from a BOI perspective, trying to get the employers to include it on colleague engagement surveys if you're doing it, to get some random solicited feedback as opposed to a survey that the clinical staff is encouraging you to take, helps with that. And asking those questions around, likelihood to, does this benefit, drive your retention status, right, or your perceived retention status with the employer. Performance guarantees, there's a plethora. Sometimes it's based, if there's an open position, based to offer employer surveys, patient surveys, and certain levels. I mean, if you're not getting a patient satisfaction score of 90% at an on-site, that's something to look at. Almost every competitor will average 90% or higher. So, which is very high in the world of Net Promoter Score recommendations and stuff of that nature. And then just looking at appointment availability, wait times, times to sign in, are some performance guarantees that we'll do. And then some of the more value-based or at-risk will do performance guarantees on per member per month cost reductions and stuff of that nature. That's not the world that we currently play in at Concentra, but it is a world that you can play in. Some employers do past experience want a set amount of case reviews per year or per quarter based on some issues they've had. So you can really draft it around the key metrics you're trying to solve for. But I would advise both parties to make sure you can report on them. Otherwise, you just get together and you have a discussion about data you don't have. So you need the systems to report on them. We won't sign up for a performance guarantee if we can't provide objective reporting on it.
Right, thank you. Darcy, how do you ensure utilization of both services? How do you communicate, how do you incentivize get people to use the OCHEalth and the primary?
So that's a great question, and the best way to do that is, again, word of mouth and having that great experience. It's important that the executive team of the employer group that we're working with has bought into what's going on in the clinic and promotes the clinic. We don't incentivize the patient to use the clinic. Some of our clients will incentivize by offering a free clinic or offering different kinds of benefits. If you utilize the clinic, you can get a discounted rate on the health plan. The clients will usually incentivize. But we will promote the clinic. We'll hold different kinds of fairs with the employer where we'll go and do like a biometric screening or things like that to talk more about the primary care. The health side, usually the employer will direct them to use the clinic for their new hire physical or their drug test, or you're injured at work, run over to the clinic and let's get this addressed. And again, that's a great opportunity to help build some utilization in the primary care side of the clinic, or part of the clinic, for that provider to start to build that relationship with the patient. I can tell you that a lot of our utilization builds have come from a patient being seen for an occupational visit. They came in for a new hire physical or an annual surveillance exam or a drug test or an injury. And while they're there, we can talk to them about the clinic and educate them on what we can do besides just taking care of your twisted ankle or coming in here for your annual surveillance exam. New hire physicals have also been a great way for us to educate patients on the fact that the clinic is primary care as well. During a new hire physical, the provider can perform a full physical, everything related to the job, but a full physical from the primary care side, and again, educate and address some issues with those patients to say, okay, well, we're going to get this taken care of so you can go to work, but did you know that you can see me for free or for a minimal charge to take care of your blood pressure, your diabetes, and your cholesterol, and your thyroid, and come in here for your annual exam, and let's get your vaccines up to date. And did you know you could use the clinic and explaining the difference between the two and what is reported to the employer again and what isn't, and helping to educate them, and that's been the biggest driver for utilization.
Right. Okay, how have you been able to increase utilization? What's your strategies?
I think Darcy touched on a lot of them, but communication is key, and then just continuing to promote it. You can't just do it one time, because we have employee turnover, and we have users of the clinic, and then you have people who just forget that it's there, right, until they actually need something. So I think relaunching different campaigns, blood pressure checks, but prior to wellness. In November, when we do our benefits, usually in September we start with biometric screening and pushing that, because if they go to the clinic and get the screening, again, no copay, then they get a discount on their medical plan. Right now, we've had a lot of interest, and actually Concentra came to us that they were getting a lot of people with these new drugs that are out there for weight loss and diabetes. A lot of people seeking to get into that, and so they came to us and said, hey, how about if we do this, like a Biggest Loser campaign? And so we're currently doing some weight loss incentives, if you will, leading up to our benefits enrollment. So a lot of communication and relaunching campaigns, getting the providers, because they're there out in our warehouses to meet and greet the people, offer athletic trainer services to leading the stretching exercises, or how about blood pressure checks, and then we see an uptick in clinic utilization at that time. So we just have to continually be on it, educating the people.
Mike, utilization strategies here.
Yeah, so like Darcy said, we're kind of fortunate in the health world because of direction, but there are states where you can't direct, such as Maryland, where it's a free choice state. So aside from the patient experience, again, it's a little, I think, easier in health because we can go out on the floor. There's more of a reason to be out on the floor. Show me what you do. I want to understand, any risks that may be at your workstation, or how to, what barriers or restrictions should be in place to get you back to your workstation, say a manufacturing plant. So that we're big on the floor engagement with all of our clinicians, especially the patients like to see the clinicians, like to know that the clinicians understand what they're doing. When it comes to the primary care side, everything that was mentioned, I think another area is utilization of the patient portal, especially if there's an app, so some sort of incentive to sign up for the app, then that turns on another opportunity for more engagement to be driven electronically through the app, and any messaging you can do there. I think we covered most of the other.
Okay. We're going to have a separate session on utilization later today, so we'll go into much more detail on that. Mike, talk about the state laws and how they differ for workers' comp or occupational health versus primary care, and what employers need to consider when looking to integrate these services.
Yeah, so there's, I would say this navigating primary care laws are much easier than the comp laws. They're more universal. HIPAA, privacy, your typical CLIA type stuff that you need to operate at a level of your clinical capacity. Workers' comp varies by state. So you have to research and know, are you a panel state? Is that a 60-day panel, a 90-day panel? Is it a free choice state? And there's some, even though you have an on-site clinic and it's free, you still have to, in some states, post a panel and offer to the employee when they come in. You have two other options that you can go to for your services. And then it goes to the next level, understanding how that works with referrals and follow-up care after referrals to specialty. So that's really something that you should be sitting down with your risk and your legal, whoever's overseeing the workers' comp side of your business, and you should have a discussion with the provider about how they're going to navigate the state laws and make sure they're aware of the state laws. And then usually, there's various ways to set up the reporting. You also have to, most people that are using on-site are self-insured, but not all. And there are still some payers out there that don't want $0 claims, so you got to make sure you check on the payer side of things. And sometimes there's a third party involved in there that would like to reprice it, even though the employer is paying for it on site. And so you got to make sure that you don't have a third party that's repricing something from an on-site, which they really shouldn't be doing when you're not collecting, the provider's not collecting. And in some cases I found out people didn't even realize that they were being paid fee for service. They were paying, usually it was like a small provider that doesn't really do on-sites, but they're paying them fee for service and cost plus to be there. They didn't realize they were submitting claims. So just making sure that you understand from the employer side what's happening there.
Darcy, anything to add? All right, you mentioned about the medical records. So what do employers need to know about if they want to integrate this? Can you have a single medical record system? Do you have to have separate ones? Do you have a single one? What's the approach? Darcy?
It's best if you have two. Keeping occupational health separate from primary care is mandatory. You don't want any occupational health and primary care mixing. Again, with reporting with regards to occupational health, you don't want that primary care record involved. So it's best to have two separate softwares to keep that. It's possible to do it with one. But then you have to create different charts, and it increases the error rate if you accidentally charted the wrong rock health chart or primary care. So it's better if you've got two systems.
Okay, any comment, how do you handle it?
No, I have to actually punt to Mike because I don't do the filing.
Yeah, so I agree with what Darcy said. You either need, if they're paper records, they need to be separate. And even though a lot of times in an on-site situation for Occupational Health, they're expecting the provider to keep the lifetime records, so chest x-rays, stuff of that nature, when you have surveillance, medical surveillance happening. They're expecting the on-site provider to organize them, but the employer is responsible for maintaining them. So making sure you understand the surveillance laws and how that applies to you and OSHA. If your system is set up to separate them, which ours aren't, sounds like Darcy's, or most systems are set up to separate them, that makes it easy. And we have two separate practice management systems, one in one. And so that does all the digging up and reporting. But they are different, and in general, your Health can be very complex because sometimes you're using medical surveillance software and an EMR and a practice management system. So it depends on the level you're on site and what level of surveillance you need to maintain for the risks and the safety concerns at your particular employer location.
So every employer's got certain space limitations. So for care, has it been a challenge to have Health and primary care in the same area? It's enough space for different providers, and I don't know if you have physical therapists, chiropractors, and acupuncturists, as well as physiologists. I mean, how do you approach that, and has that been an issue?
Our clinics are, I would not say extensive, and we have mostly athletic trainers, nurse practitioner, and a medical assistant. So we do offer, prescription services depending on the state. And the biggest thing is being able to have, at least for us at least, and when I say we're a family company, I said that earlier, but we're at 22,000 employees. Our company does treat everyone as if they're a family, and we have 3 on-sites. We're expanding this year to 3 additional on-sites. But we currently have 2 or 3 exam rooms. We do pre-employment testing there, so we have some physical abilities testing that we do to make sure that the people can actually do the job that we're hiring them for prior to putting them in that role and then maybe sustaining an injury. And then we also have a space for an athletic trainer in addition to the clinicians. So I'd say the key for us, the very first one we did not have it open, an exterior door open to where we could see the dependents. We wanted to try it first. And so everyone has to come through security to get into the building, and it's caused a little bit of a challenge that excluding 2 dependents. The other 2 that we did were available from day one with an external door to the dependents, and that's worked a lot better.
Mike, can you talk about space issues?
Yeah, so I think what Kay said was clear about dependents. So making sure if you are a high security location, if you're planning on seeing dependents, you need to be able to have an access plan for them. The space is always an issue. It's an issue when you open up a clinic. It's really understanding, the population, the scope of work, and really trying to forecast what is going to be your engagement. So if you have a very busy health clinic, most employers are not going to say, well, let's just throw primary care in there as well. They may have to find another location or have room to expand. A lot of times we'll work with employers on a phased approach where, we set aside 8,000 square feet, but we start using 3,500 and we don't install x-ray, then later x-rays installed, the ultrasound is installed, a couple of years later, add a few more exam rooms. So if your long-term plan is to include it, leaving a little room for growth is important. But otherwise you have to manage it with multiple sites and figuring out other items. It's, same issue as if you add a new wing to your manufacturing company, you bring on 2,000 more employees, and you probably don't have the space in your on-site.
Space issues. For example, can physical therapists and chiropractors use the same table, or do you have to new tables? How do you handle space issues?
it really depends.
Yeah.
It really depends on what you want to do, and what services, chiropractor, physical therapy, they could share. Physical therapy, you're going to have different exercise equipment and things like that that you may need to bring in. It really just depends on what services and what health exams we're going to be doing in the clinic. If we're, we may need a room for flexibility, mobility exams, or some different equipment depending on the type of exam that needs to be done. In most cases, if it's a simple health and we're not going to expand bigger, if that's not the goal, we're going to do some simple health and primary care, you could do it with 2 or 3 exam rooms. But I agree with Mike, plan for expansion. Because you go in thinking, okay, this is what we're going to do, and once it becomes successful and you've got more and more patients using it and utilization is growing, and you're maxing out all the space for health and primary care, yet you're 2 and 3 and 4 and 5 days out for patients to be seen for that primary care, it's time to start thinking about growing that. So plan for that in the future. Don't just come in and go, okay, I've got this one room and a little bathroom off to the side, and that's where we're going to stick our clinic. Because when it grows, you're going to need that space. So plan for that growth.
Thank you.
Larry, I want to just point out that one of our locations, we actually did not have the space to be able to build it out. So we've had 2 where we've had a really great build out that, from a budget perspective, was allowed. But in this other market, we were concerned because you can direct the care for the first 30 days, and then they don't have to come to the clinic. And in fact, based on a union contract, we have to tell them up front, and they may not come to the clinic. And so we were concerned about utilization and overcoming that challenge. So we set it up in a trailer, basically, in the parking lot, and it has been successful. A little bit more communication needed for that, to get the people to get right there, right? Because they have to go outside to get there, but it was still right in the parking lot.
Great, thank you.
Yeah, I'm going to add one more thing, Larry, too, to say. And that's that when you're doing primary care non-health, sometimes it makes sense to look at what other services you can bring in. So if you're a large steel manufacturer or a shipbuilder per se, and you've got a lot of surveillance, you've got a lot of primary care needs, instead of staffing enough colleagues in your clinic to maintain all of that stuff on an annual basis, 365 days, you can work with a mobile partner, bring in episodic staff once a quarter, once a month, where you have folks that drop in to do a high volume of surveillance tests, exams. Audiology is a big one Mobile likes to do, but I would advise you to bring a mobile vendor and make sure it's somebody that can do more than just hearing exams when they come on. Because if you need hearing exams, you need other stuff too. And you can knock that out quarterly versus having 10 FTEs at an on-site all year long. You can maybe go with 8 FTEs or 7 FTEs and offer more services because you don't have those compliance exams or compliance services clogging up your clinic. So it allows you to operate with a little smaller space. Takes a little more planning or a different thought process, but it is a way that we're seeing employers kind of use a smaller space, staff all year long, but then you ramp up for some peak season stuff. And you said it, you don't have room to expand your clinic, so you bring some other options in.
Makes sense. So typically, let me ask you, okay, Health is handled by risk management, primary care is handled by HR benefits. Are there internal issues you have to deal with if you want to consolidate or integrate these services?
I think you have to have good collaboration. So everything that goes with our clinics is a combination from our HR benefits team, risk management, and health and safety. We were the champions for the program, and we had built a relationship with Concentra. Our risk management team used to be, and then we spun them out, but we still work collaboratively on everything.
Mike and Dr. Darcy, any comments about the need for employers to plan this internally before they move forward?
That's the best advice we can give an employer is we've got to work together as a team for this. Because yes, Occ Health usually falls under risk, and the clinic will usually fall under benefits. So those two departments need to be able to communicate and to collaborate on things that are going on in the clinic. It's very difficult for us in the clinic when we get something from risk and then something from benefits, and we're like, but wait, these are contradicting each other. So having the two teams collaborate, and one of the things we do is we have monthly meetings with our clients, and we'll have both teams or the leads from their specific teams on those meetings so that we are collaborating with them.
Okay, lastly, my last formal question, then we'll go to audience questions. Success factors for integrating Occ Health and primary care. Mike?
I think we hit on a lot of them already. I just think communication up front and engagement of key decision makers. So what Darcy just said, making sure you know who's the decision maker and who's invested in the on-site clinic from both the primary care and Occ Health perspective. That also helps to greatly drive engagement, because if you don't have the right stakeholders at the company, then you usually struggle with engagement because you can't get in front of the employees in a way that you need to educate them about the offering.
Okay, there's success factor. Okay.
I don't think I have anything to add to that. I think we've mostly touched on everything that we measure and how what we're measuring for success.
Darcy?
I echo everything you said. I think we've touched on it.
Fair enough. All right, so let's go to audience questions then, the ones I've got here. In your experience, what EMR challenges, if any, do you face when providing primary care and Occ Health in the same work setting?
We haven't had challenges just because we were fortunate enough that our organization turned on urgent care as a larger organization. So to do primary care at on-sites, it was already sort of bifurcated in the reporting setup. So we haven't had any issues.
Next question. Have you ever seen a case where a primary care doctor was seen for an Occ Med injury for return to work that became a legal issue?
So legal issues always pop up here and there for various reasons, and your best defense is a great patient experience, and most clinicians and medical operators will tell you that. I think the legal issues are going to pop up from the folks that are going to do that, regardless of everybody's best intention or performance. But specifically, have we come across a legal issue that is related to having Occ Health and primary care in the same site? No, we have not.
And I'd echo that. We haven't had a legal issue that has come up with a primary care provider and an Occ Health, doing an Occ Health or vice versa. I think education and documentation and patient experience are the best preventer of that legal experience.
All right, my last question I've got here. What if not one of those issues that can be handled in the primary care setting? What if an issue such as disability ratings, fictitious symptoms, malingering, can't be handled in primary care? Does that help handle that? How do you address that? And does this exceed the states where patients are allowed to go where they want to work with?
So first, very rarely, well, I guess you have malingers or frequent flyers for both primary care and workers' compensation. So if they're going to fly frequently, it's better at a cost-plus model at your location so they can get back to work, because you know where they're going, you know their shift time, and they know where they need to go. It absolutely works in cost or free choice states, both on-sites. I think we operate, 24 public medical centers in the Maryland area. And back when I used to know what a physical therapist did, mine was legally one. I had a patient ask me, give me the side eye and sort of say, why should I trust you? Why should I be here because my employer sent me here, my response was, well, you're in Maryland, you can go wherever you want, so if you really want to leave, you're welcome to call your primary care physician or go wherever. Her whole complexion changed. And so 20 people are here and they could go anywhere. I'm like, yeah. She's like, okay, I'll stay. She stayed. It's a great patient. So, malingering is it's in reality, if you don't deal with it all the time, I just say it's very rare, although they tend to be a high-cost case. So having an on-site and the close case management, the closer proximity of the physician who's only dealing with your employer team, as opposed to 100 other clients that use our clinic, really helps to facilitate that process and keep it as short as it can be.
Thank you. We have a question? Hold on. That's okay.
I work with the utility company and deal with a number of, not clinics within our own, but in different states where they're occupational primary. And I found, of course, that each physician has strengths and weaknesses, and many primary care physicians aren't good musculoskeletal physicians and that sort of thing. So what the types of injuries have to deal with, so there are many providers who can do good level 1 work, the basics, physical, suture stuff. We have a lot more complicated injuries now. They're overriding. It may be injury plus substance abuse. It might be injury plus behavioral. And so I call those fitness for duty. Do either of you try to hook up or put in your system a third-party occupational physician to handle those more complex evaluations that your providers can't do, or may not be comfortable?
Yes, we do. We do have an occupational medical director that her specialty, she is board certified in occupational medicine. And so, yes, when we have those more complicated, our providers engage her for those. And again, still trying to keep it as much in-house as possible.
Yeah, and we have a national network of occupational health physicians that we can leverage, and they do oversight. So all of our sites have medical oversight and operational oversight to help with those cases.
So this is kind of a similar-ish question. So as we integrate much more mental health into primary care and into on-site, your site clinics, I'm curious about how you see mental health affecting the occupational health and vice versa, or injury prevention and things like that. Could you speak to that, Brenda?
Yeah, so we get asked about behavioral health all the time. And it should really, as you heard earlier, it should be part of a well-rounded program. So when you're on-site, I think looking at the structure of your on-site, are you going to bring your EAP in? You bring a third-party vendor in? Are you just going to do screening to identify risk ahead of time? So that, to me, is where we move forward over the next few years, I would say the majority of on-sites will have some sort of behavioral health component. When you talk about injury prevention, we have found that athletic trainers are really good at engaging the employee, addressing concerns, and teasing out that sort of behavioral health component of fear. So you have the whole, in the comp world, you have the whole fear avoidance-based issues and stuff that you can look at. And the athletic trainer is great in the prevention model for both allaying concerns, showing people how to be comfortable with their workstation, and preparing them for work.
Okay, I have another question. Is anything outside health or urgent care considered primary care? If you do an annual physical or travel vaccine, do you need to separate those records?
We do. If it's a primary care annual exam, we separate that record from a workplace exam, a return to work, or an annual surveillance exam. Those are separated out. Travel vaccines, it depends on if it's required for their job. if it's, you know, a specific company where their employees are traveling around the world and they've got to have specific travel vaccines related to work, then that would go on the OCAP side.
If no other questions, let's thank our panel for